Thank you everyone for coming to my presentation today, demonstrating the utility of new linked National Health Survey and administrative data, secondary cardiovascular disease prevention in the community. My name is Danielle Butler. I'm a GP and Research Fellow with the National Centre for Epidemiology and Population Health at the Australian National University. Firstly, I wish to acknowledge my study team, Associate Professor Rosemary Corder, Dr. Jenny Walsh, Dr. Linnell Moon, Dr. Ellie Page, and Professor Emily Banks. So we know that CVD events are largely preventable through access to quality primary health care and use of guideline recommended therapy, and that this is through CVD risk reduction. Recent data has found that around half of Australians with CVD are not receiving best practice treatment, and this is based on self-report. However, there's limited data and factors associated with undertreatment in terms of who are not receiving treatment and to what extent this is about their primary care use. Further, there's limited data on variation in secondary CVD care in terms of primary care, ambulatory specialist care, and medication use and adherence. So the aim of this study was to quantify variation in secondary CVD care in relation to sociodemographic and health characteristics. And we were interested in looking at use of recommended preventative medications and primary care and specialist ambulatory care provision. For this study, we used data from the Multi-Agency Data Integration Project, or MADIP. This is a partnership among Australian government agencies to combine information on healthcare, education, government payments, personal income tax and the census to create a comprehensive picture of Australia over time. Underpinning MADIP is the person linkage spine, and this is used to create a person level identification key by linking data from 3 administrative data sets. This results in a virtual complete coverage of the resident population. So these 3 data sets include the Medicare enrolments database, which is the records of those covered by Medicare, Australia's universal health insurance, the Social Security and related information database, which is the records of those receiving government benefits, and the personal income database, which has records of those who lodge a tax return. The high coverage of the spine enables a high quality linkage to other data sets. For this study, we used the 2014-2015 National Health Survey, which was linked to MBS and PBS and death registrations data via the spine. Linkage was performed using deterministic and probabilistic linkage methods, with a linkage rate of 95% for the NHS and 97% for the death data. A direct link exists between MBS and PBS data and the spine. We use this linked data to create a cohort of those with self-reported CVD. In the NHS, this is a nationally representative survey which includes sociodemographic and health information with an overall response rate of 82%. The MBS data includes claims data under Medicare, including out-of-hospital services and costs, and the PBS includes dispensing data of government subsidised medications. In our study, we followed participants up for the year following completion of the survey, and after excluding for those who died in the follow-up period who were unable to be linked to the spine, we had a final sample of 892 participants who had self-reported CVD. So we use logistic and negative binomial regression to estimate odds ratios and 95% confidence intervals for use of recommended treatment, the number of GP MBS services and specialist use in relation to participant characteristics. Characteristics of interest included sociodemographic variables, health risk behaviours, and cardiovascular disease risk factors. For medication use, this was defined as at least 2 dispensings of both a blood pressure and lipid lowering medication per quarter over a 12-month period as per current Australian guidelines. And we used the ATC codes to identify medications. In our study, overall, around just under 40% were on guideline recommended therapy. In terms of those who were more likely to be on recommended therapy, those who were older, who were of male sex, and who had a concession card were more likely to be on recommended therapy. whilst in terms of health characteristics, after adjusting for age and sex, those with CVD risk factors, the number of health conditions, and those with increasing GP use were more likely to be on recommended therapy in the year following completion of the survey. In terms of specific health risk behaviours and CVD risks, so those who were obese with self-reported hypertension or elevated lipids, self-reported diabetes and renal disease were all more likely to be on guideline recommended therapy. We did adjust for health status, and overall the patterns remained unchanged. In terms of primary care use, we found that those who are older, who are female sex, with lower educational income, had increased use. In terms of health characteristics, the patterns were somewhat similar to medication use, in terms of those who are obese, had diabetes or poorer health status, had a greater use of GP services in the year after completion of the survey. On the other hand, those who had harmful alcohol use or sufficient physical activity were less likely to see GPs. Again, after adjusting for health status, the relationship between the health risk behaviours and cardiovascular disease risk factors were largely unchanged. In terms of specialist care, again, those who were older with private health insurance were more likely to see a specialist in the year after completing the survey, whilst those who were more remote or overseas born were less likely. Smokers and those who used more GP services were also more likely to see a specialist in the year after completing the survey. However, there was less variation between groups in terms of health risk behaviours and CVD risk factors. Again, having adjusted for GP use and health status, the relationships for cardiovascular disease risk factors was largely unchanged. In terms of whether the associations between CVD risk factors and health risk profiles with medication use was related to their underlying primary care use, we additionally adjusted those models for primary care use as well. And while there was some marginal attenuation, absolute values and the significance remained unchanged. So in summary, those who were more likely to be on recommended therapy were older, male, of lower socioeconomic position, had more CVD risk factors, and saw GPs more often. Patterns of relationship were largely similar for GP use. However, there were some additional health risk factors that were associated with increased GP use in this cohort. We also looked at continuity of care, which is a measure of dispersion between providers, and overall there was little difference in continuity of care between the groups for this particular cohort. Those who were older with private health insurance and saw GPs more often were also more likely to see a specialist in the year after completing the survey. And overall, the variation in medication use according to health risk profile was not just related to their underlying use of GP services. Finally, this study demonstrates the importance of the MADIT resource in the future for answering policy relevant questions in a timely manner. I wish to thank you all for listening, and should you have any questions, please don't hesitate to get in touch. Thank you very much.